Так, значит,
Влево-вправо. Так, я звук проверил.
сейчас, минутку. Вы уже работаете, уже мы в эфире. Я вот могу листать вот это туда-сюда, а влево-вправо?
То же самое.
Туда же. Угу. Хорошо, можно начинать. Let's start, my dear colleagues. Good afternoon. My name is Vladimir Alexandrovich, surname Chabanov. I am docent of urological department. And now we will discuss very important discipline, which is very often in our patients. Urinary stone disease, and independently on your future specialties, you will meet this category of patients. But registration continues. Not all students are ready to listen to our lecture, and few words about organization of our lessons. When you visit our cycle of urology, first lesson you must be preparing already. I recommend you textbooks written by Shimkus. These textbooks are enough in our library. And first lesson you must prepare symptomatology of urological diseases, as well as instrumental and radiological methods of diagnostics of urological diseases. I am repeating once more, symptomatology of urological diseases and methods of instrumental and radiological investigations in urology. And now we'll continue. Urolithiasis is one of the most widespread diseases of urological patients, which doctors of different specialties encounter. Urinary calculi are the third most common affliction of the urinary tract, exceeded only urinary tract infections and pathologic conditions of the prostates. The occurrence of stone within the urinary tract is a problem that has plagued humans since the beginning of recorded history. Archaeologists have uncovered urinary stones in the mummified remains of Egyptians, estimated to be more than 7,000 years old. What term can we use for this disease? First, urinary stone disease. Next, urolithiasis, and nephrolithiasis. All these terms means that patient suffers from this disease. Well, there are numerous theories of originating and development of urolithiasis. However, any of them does not explain completely its origin. Nephrolithiasis should be introduced as the disease of the whole organism, caused by different disturbances of metabolic processes and formations of stone in the urinary paths, with subsequent manifestations and complications. By chemical composition, we distinguish oxalate, phosphate, urate, carbonate stones. Sometimes we meet cysteine, statine, and other more rare. Next, epidemiology. This picture demonstrates that frequency of the disease is enough high, between 120 and 140 people per 100,000 will develop urinary stones each year. Next, you can see the frequency of this disease in United States, and you can see that prevalence of stone disease has risen from 3.8% till 5.2% during 20 years. In the United States, stone disease accounts for more than 400,000 hospitalizations annually. It is enough high figures. The peak incidence is in the 3rd to 5 decades. Stones form in the collecting system of the kidney due to a multitude of factors, most often an imbalance of anorganic substances such as calcium, struvite, urate, or cysteine due to an underlying metabolic disorders leads to matrix formation in the urine. Any obstructions to urine flow can lead to stasis of the urine and increased risk of stone formation. Reduced urine volume and dehydration may tip the balance in causing stone disease due to supersaturation of the urine. Medical conditions such as Crohn's disease lead to increased level of certain substances that may be predisposed in individual to stone formation. The etiology of stones remains speculative. For example, if urinary constituents are similar from each kidney, and if there is no evidence of obstruction, why do most stones present in unilateral fashion? Why don't small stones pass uneventfully down the ureter earlier in their development? Why do some people form one large stones and others form multiple small calculi? There is much speculations concerning this and other questions. The development of stones in the urinary tract is a complex, poor understood, multifactorial process. We can divide the numerous factors contributing to stone formation into exogenous and endogenic, and the later into general and local. First, you can see geography. Prevalence of stone disease is higher in mountainous, desert, or tropical areas. Countries with a high incidence of stones are the United States, British Isles, Scandinavian countries, Mediterranean countries, northern India and Pakistan, northern Australia, southern Europe, Malaysian Peninsula, and China. Reasons for geographic and climate variances are unclear. Climate. dehydration, and increased production of different vitamins may also can lead to the stone formation. Urinary stone disease is more common in sunny, warm climates and seasonally during summer months. Next, occupation. Even occupation influence on the stone formation and frequency of stone formation. Occupation can have an impact on incidence of urinary stones. Physicians and other white-collar workers have an increased incidence of stone compared with the manual laborers. Even social economic factors also take part in these kind of questions. Affluent societies have higher rates of small abstract stones, whereas large true white stones are more common in development countries where malnourishment and infection are common. Bladder stones tend to be more common in underdeveloped countries and may be related to dietary habits and malnutrition. Diet next. You can see diet excess intake of dietary sodium, oxalate, calcium, and purine increased risk of stone disease. Hydration, hypervitaminosis, etc. What means endogenous factors? It means they may be general and local. As we said, different metabolic processes leads to changes in metabolism and composition of urine, which is predisposing factor of stone formation. For example, hyperparathyroidism. Hyperparathyroidism is one of the variants of this disbalance. Hormone of parathyroid glands leads to changes of calcium phosphate metabolism, and building material appears in urine more than in normal. Uric acid diathesis, you know that purine metabolism, and ending product of this metabolism is uric acid. Hyperproduction of uric acid is predisposing factor also of stone formation. You know that other disease which also is caused by uric acid diathesis is gout. But combination of gout and uric acid stones are very rare, only in 50%. Next, hyperoxaluria, vitamin disbalance, bone fractures, bowel disease, bone fractures. Why it's a predisposing factor for stone formation? No, first of all, changes of metabolic process in organism, which is directed on regeneration of stone and of bone, and bone formation. On one hand, on the other hand, these patients long-term are immobilized and you know that in horizontal position, urodynamic less in 1.5 time less than in the usual regimen. And next, local causes, urinary obstruction, as I said, infection, tubulopathies, vesicoureteral reflux, anomalies. In all these cases, disturbances of urine flow takes pad. So any cause which disturbs urine flow may be cause of stone formation. What are the most often ions in urinary? Calcium, oxalate, phosphate, uric acid, sodium, citrate, magnesium, and sulfate. Stone frequency. Most often, stones are oxalate. More than 55% are oxalate stone. Next, urate and phosphate are approximately the same, 15 to 20% urate, phosphate 10 to 16%. More rare may be carbonate and very rare cystine stones. What can we say about the stones? Some stones formed in the acidic urine. In this table, you can see these primary stones. They include oxalate, urate, uric acid, and cystine stones. They formed in normal urinary tract due to metabolic errors. They formed in acidic urine, no central nucleus in these stones. Secondary stones include phosphate stones formed in infected urine. So first infection and secondary stone formation formed in alkaline urine. In inflammation, urine most often is alkaline. There is central nucleus, which may be primary stone, clumps or organism, blood clots or tissue debris. Characteristic of stone. You can see urate, oxalate, and phosphate. Urate stone, ammonium urate or uric acid stones. Most often the number variable, size small, shape rounded, surface smooth always, color yellow or reddish brown, consistency hard, and cut section, no nucleus. Oxalate, calcium oxalate most often, single most often, size moderate, oval, spiky, LS symptoms due to this surface. Brown or black, very hard, and no nucleus. And phosphate, usually calcium phosphate, it may be other combinations. Variable number, large stones, oval, smooth. Few symptoms will it has large size. Dirty white color and hard and friable. Nucleus and lamina. What about localization? Localization may be different. Localization of stone. They can form from calyces. Next, pelvis. They form in pelvis, and then they can migrate along ureter. You can see different places when maybe stopping of the stone. No, first of all, the piloureteral segment may be place of fixation of stones because it is first physiological narrowing. Next, maybe in place when ureter cross iliacal vessels, and last narrowing when ureter enter into the urinary bladder. And in these places may be localization. In the urinary bladder, most often secondary stone, which are caused by infravesical obstruction, when some obstruction of urethra lower than urinary bladder. Most often it caused by benign tumor of prostate gland, BPH. Well, because if stone migrated along urethra and it went out into the urinary bladder, in cases when infravesical obstruction is absent, the stone might go out through urethra because diameter of urethra more than diameter of ureter. This picture also demonstrates possible localization of stone. In urethra, very rare, but it's also possible, and in this case, the situation may be complicated by acute urinary retention, when urinary bladder is overdistended and patient has not independent voiding. Symptoms of urolithiasis. Symptoms. Pain is the most often symptom, and depending on obstruction, pain may be acute or dull pain. If urine flow is disturbed completely, when complete obstruction presence, may be acute pain. And when partial obstruction, pain may be dull. What stones cause more severe pain? Small stones. Why? Large stones, more than 1 centimeter, they localized in the pelvis, in pylocalycial system. They disturb urine flow, but only partially. What about small stone? Small stone can obturate pyloureteral junction along ureter, also may be obstructed. An example of acute pain is renal colic. Renal colic, I think that you already hear these symptoms, and it may be till 80 to 85%. How does it develop? It develops very fast, very quickly. Why? Sometimes it may be developed on the background of complete health. For stone, when it immigrates along the ureter, it irritates nerve endings which are in mucosa of ureter. Refractory spasm appeared. Refractory spasm, and this spasm obturate completely ureter in place of localization of stone, complete obstruction. Kidney continuous excrete urine, and excretion of urine is about 1 ml per minute. 1 ml per minute. Capacity of pylocalycial system is approximately 5 to 7 ml. So 5 to 10 minutes is enough to enlargement of pelvis twice. Distension of pylocalycial system develops, and ureter which localized upper than stone. Patient feels acute pain. First of all, pelvis tries to push this stone, to push this obstruction and it constricts more. But by this way, pressure in pylocalycial system increased more, and pain also increased. This pain localized in the lumbar region. If one point, it may be angle between 12th rib and direct muscles of back. In this picture, you can see approximately this localization and very characteristic radiation of this pain. It radiates downward along the ureter, in the iliacal region, in suprapubic region, groin, and even sometimes in internal surface of thighs. Such characteristic irradiation. This fast development is very important differential diagnostic symptom. Later we will discuss it. Next, hematuria. It may be microscopic or gross hematuria. Microscopic till 90%. Erythrocytes urea by other words. A gross hematuria may be in 20 to 25% of patient. And most often cause of gross hematuria is a rupture of fonical veins, which localized in the calyces of kidney. And when changes of pressure in biolocalycial system occurs, maybe rupture of these thin wall vessels and gross hematuria. Frequency or pollakiuria, you can meet this term in your textbooks, maybe till 40 to 50%, and most often in localization of stone in distal part of the ureter. Sometimes stone can migrate along the ureter 1 week, 2 weeks, sometimes when sizes of stone less than 5 millimeters. And at one moment, patient says to doctor, from yesterday evening, for example, I feel frequent urge to void. It may be indirect symptom that stone descended downward and localized near urinary bladder. Pyuria 65 to 70%. Most often it is result of secondary pyelonephritis. Nausea and vomiting 10 to 40%. Maybe as a result of refractory irritation of bowel. And passing of stones with urine 45 to 50%. Now it may be stones or crystals. I think you know already what means pathognomonic symptom. Pathognomonic symptom is symptoms which is the most often in this disease. By other words, only in this disease it is characteristic for this disease. And this symptom, passing of stone, we can call pathognomonic. For example, if a patient says that he has passing of stones with urine, and he has experience of this passing of stones, we can think about diagnosis of urolithiasis. Next, complications of urolithiasis. The main problem is obstruction. And long-term obstruction leads to dilation of ureter and pyelocalycial system. It leads to hydronephrosis, hydronephrosis, distension of pyelocalycial system, hydroureter of ureter. Well, infection, it is secondary pyelonephritis most often due to stagnation of urine, and it leads to pyelonephritis, pyelonephrosis, ascending pyelonephritis to the other side also. Other stone formation also, stone migration, and post-renal anuria. Post-renal anuria in cases of bilateral obstruction, when from both sides obstruction presence. For example, right and left ureter is obstructed. Because if only one side will be obstructed, other kidney will excrete urine. Post-renal anuria, it is very serious obstruction. Renal failure is a result of long-term obstruction and long-term infection, which leads to gradual atrophy of parenchyma. And I'll demonstrate you a picture in which you can see this process. In this picture you can see kidney, upper half of kidney is not affected, and lower part you can see the dilation of the calyces, hydrochalicosis, and atrophy of parenchyma, the gradual atrophy of parenchyma. More demonstrative is in this case. Look, pyelocalycial system is filled by this stone, and small stones are in the calyces. You can see that functional parenchyma is absent because sclerotic processes leads to atrophy and sclerosis of this parenchyma, and gradually kidney lost its function. Next picture you can see the thin layer of parenchyma and sclerotic tissues, and the vacant parenchyma is absent already in this case, and stone intercalyces. In this picture you can see so-called Steckhorn stone. It picture similar because these parts of this stone, they localized in the calyces. This part localized in the pelvis. This stone was removed during operation. This part of stone was removed through incision of pelvis. This part of stone was removed through incision of parenchyma. Name of this operation, pyelonephrolithotomy. Also, example of Steckhorn stone, approximately 1.5 inches. And also this part was in the pelvis, this part in dilated calyces. It is phosphate stone. Most often Steckhorn stones are phosphates. This picture you can see example of post-renal anuria. This shadow, it is large stone which localized in the distal part of the ureter, and it reached these sizes in this place, and long-term obstruction of the right kidney leads to loss of function. Right kidney is not functional kidney already. Left side, this shadow of stone, obturation of ureter occurs, and bilateral obstruction. You can see shadow of ureteral catheter, which was inserted into the ureter for restoring of urine flow. in cases of postrenal anuria, we must restore urine flow by any way, or maybe through ureter if it's possible to insert apathene obstruction. If it's impossible, percutaneous nephrostomia performs for drainage of kidney. Diagnostics of urolithiasis. First of all, complaints and history. Our scientists said that till 50% of information in diagnostics we can receive from a detailed interrogation of patient. You must ask him about symptoms, about history, by what way it developed, that is disease, what manifestations, what actions were performed, diagnostic treatment, etc., etc. Physical examination. During physical examination, you can determine areas with pain, and it is very important in differential diagnostic of renal colic and acute surgical diseases of abdominal cavity. Laboratory investigation, urine and blood. First of all, we can determine signs of inflammatory process in blood, for example. We can determine changes in urine which are characteristic for urolithiasis, such as microscopical hematuria, proteinuria, leukocyturia, crystalluria, depending on variant of crystal. We can suspect each other stones. For example, in case of oxaluria, we think about oxalate stone. If we can say uric acid crystals, so it is indirect symptom that patient has uric acid stone. Analysis of any stone past, it is very important because for prophylaxis of this disease, we must recommend to patient each other diet, different drugs for prevention of recidivation of this disease. Most often we can analyze stones which pass through independently or which were removed during operative or instrumental methods of treatment. Ultrasonography is very important. It is non-invasive method of diagnostic and enough informative method. We can determine stones of the kidney from 4 to 5 millimeters and more. Next, plain X-ray, cube field X-ray without contrast substance. We can determine shadow of stone. We can determine localization of the stone, sizes of stone, etc. It is very important investigation and in diagnostic of urolithiasis. We will say that uric acid stones are non-opaque stones. They don't give shadows on stone. And for determining of the uric acid stones, it is very important. If we cannot see shadow on plain film and receive direct symptoms in excretory urography, in this case we can be sure that stone really urate, and treatment may be very specific. Excretory urography. Excretory urography means, I will tell you about excretory urography when I demonstrate picture. Retrograde ascending ureteropylography, when we introduce contrasubstance upward through ureter to pelvis. Cystoscopy, ureteroscopy, and radiological investigation allows us to estimate urine flow, and CT scanning and MRI, these modern methods which allows us to determine these stones. In this picture you can see stone of the kidney and shadow behind it. Also this film demonstrates kidney and stone which localized in the pelvis behind it, shadow or echo-free zone. We can call it also echo-free zone or shadow behind this stone. This picture demonstrates also stone of the kidney. You can see parenchyma and stone and shadow behind this stone. In this film, we can see a small stone which localized in the orifice of the ureter, cavity of the urinary bladder, and stone of the orifice of the ureter. Plain film, we can see shadow in projection of the kidney, but this film allows us only suspect stone. Why? Because different other formation can give the same shadow, such as stone of the gallbladder, foreign bodies in the bowel, petrificated lymph nodes, petrificated tumor, petrificated cyst of the kidney, etc. And so we can only suspect that in projection of right kidney, shadow presents such sizes, such shape, etc. Next, in this case, more information that it is stone. We can see kidney, we can see very clear kidney, and the shape of this shadow is the same as pelvis, the triangle shape of this shadow stone. Bilateral staghorn stones, you can see shape as bilocalicial system. This part localized in the pelvis, also here, and this part localized and in a bilocalicial system. And bilateral staghorn stone, they fill a whole cavity of bilocalicial system. Why do they reach such sizes? Because they develop without pain. As you remember, we said that large stone localized in the bilocalicial system, and they stops urine flow only partially. And so maybe some dull pain, and sometimes patient thinks that they cause by radiculitis. Also staghorn stone in the kidney, and you can see it's a removed staghorn stone. In this film we can see stone of the ureter, and stent was inserted into the bilocalicial system for drainage of left urinary paths. Stone of the ureter, we can see shadow in urethra. Very rare, but it's possible also. And this picture demonstrates excretory urography. Intravenously we introduced contrast substance, iodine drugs, different iodine drugs, which excretes from the organism through urinary system. They excreted by kidney, and when this contrast substance excretes through urethra, we can see it on the film. You can see pilocolicial system and urethra. Urine with the contrast substance gives shadow, and we can see structure of the urinary paths. Stone of the urinary bladder, stone of the urinary bladder. The same patient, excretory urography, we can see pilocolicial system, urethra, which is not distended. Left side also, we can see this picture. Multiple stones of the urinary bladder. You can see also that this patient has artificial joints. Next, sometimes the sizes of urinary bladder stone reach huge sizes. In this picture, approximately 8 or 9 centimeters. But in our days, it's a very rare situation because diagnostic might be earlier when minimal symptoms presence, maybe ultrasonic investigation performs and successfully maybe diagnosed this stone. In this picture you can see a huge stone which formed the urethra. In this case, disturbances of urine flow were present and secondary stone formed in the distal part of the urethra. Excretory urography. Compare please. Left side, normal pilocolicial system, normal urethra. Right side, we can see distension, dilation of the pilocolicial system, as well as urethra. It's also dilated. Where is cause? Here, small stone, about 4 to 5 millimeter, caused such marked dilation, ureterohydronephrosis. In this film, you can see shadow, kidney, left kidney, right kidney, and approximately near pelvis for some shadow presence. What must we do next? We must perform any investigation with the contrast substance and compare projection of this shadow and urinary paths which are filled by contrast substance. Next film, look at the same patient. It is excretory urography. We can see that the stone localized near pelvis. Pay attention. Passage of urine presence. Obstruction is partial, and so distension of pilocolicial system is not marked. This film is retrograde pyelography, when special ureteral catheter was inserted through urinary bladder through urethra, and contrast substance was introduced in the pilocolicial system, and we can see filling defect. You can see filling defect of the pelvis. It is large stone, non-opaque stone of the pelvis, urate stone. Urate, most often non-opaque stone is urate or uric acid stone. In this film, it demonstrates problems in diagnostic of ureteral stone. Shadow possible stone because projection of distal part of the ureter. In excretory urography, projection of the shadow and the ureter, which is filled by contrasubstance, the same. But when we perform other investigation, it is filmed the same patient. We inserted ureteral catheter and performed film. The same projection, but when we perform film in lateral projection, this shadow went out from the ureter, and by this way we confirm that it is not stone of the ureter. This film you can see stone, bilateral stones of the kidneys. CT scanning demonstrates bilateral stones of the pelvis and dilation of pilocalicial system also is visible on this film. Differential diagnosis. It is a very important question in urolithiasis, especially in cases of renal colic. Why? Renal colic, it is acute situation which required urgent action. It is very severe pain. But the same pain or similar pain may be in cases of acute abdomen, it's a surgical disease, which includes acute appendicitis, acute cholecystitis, perforated ulcer of stomach or duodenum, acute bowel obstruction, acute ileus, acute pancreatitis, clottage of mesenteric vessels, ectopic pregnancy in females, twisted ovarian cyst in females, acute renal artery embolism. Why it is so important for every doctor? If we decided, for example, that patient has renal colic, what will we do? We will try to remove this pain. We will try to arrest renal colic. What will we use? We will use analgesics, spasmolytics. We will use hot water bottle, for example, or hot baths. These actions can increase speed of development of this disease. On one hand, on the other hand, when we use analgesics and spasmolytics, in case of appendicitis, for example, or cholecystitis, what happens? Pain disappeared rarely, but such serious complication as peritonitis will develop without any symptoms, and we cannot determine it in time, because a few hours it will develop without any manifestation. It is very serious. And remember, this renal colic is very it is unpleasant situation. It is very painful, but from renal colic patient will not die. But when patient will have peritonitis and it will be diagnosed not in time, maybe very serious complication till death of the patient. What are differences? Acute appendicitis, we will discuss only acute appendicitis. First of all, we can see it distantly, and we can see that diagnosis of renal colic may be suspect distantly. Patient is restless in renal colic. All time he change his position and he try to find position which decrease the pain. And And so all time he changed his position. In appendicitis, patient takes one position, most often right side, on the right side, and with the flexed legs. We said that renal colic develops very quickly, very fast. Appendicitis develops gradually. In appendicitis, hyperthermia, the temperature 37, subfebrile, we can say, subfebrile temperature, 37.2, 37.6 in renal colic, not only in cases when renal colic is complicated by acute pyelonephritis, maybe temperature. Next, nausea, vomiting, maybe in both cases, in renal colic and in appendicitis differently. Changes in urine, we said that sometimes maybe microscopic or even gross hematuria. In appendicitis, it's very rare, maybe changes in urine. Dysuric manifestations such as frequency, more characteristic for renal colic and appendicitis, very rare. In cholecystitis, very important radiation. In appendicitis, pain spreads upward, supraclavicular, suprascapular the region, and shoulders, and in renal colic always downward. We said only what are the places of this radiation. And so you must remember, if you are not sure, at least 70% that patient has renal colic, don't try to arrest it. Don't try to arrest it, because I said you already, maybe different complications in peritonitis. Next, treatment. No, we can divide different variants of treatment, maybe conservative treatment, maybe instrumental treatment, maybe operative treatment, different treatment. No, first, diet. Diet depends on the stone composition. As you remember, I said it is very important, knowledge on chemical structure of the stone, and we must perform analysis, chemical analysis of stone, and it allows us to choose necessary diet. If patient has, for example, uric acid stone or oxalate stone, we will recommend him diet which increased pH of urine. Uric acid stones formed in the urine with pH 4.5, 5.5. Oxalate 5.1, 5.8. And phosphate stone forms in the alkaline urine. So in uric acid stone, for example, we will try to increase pH of urine. In cases of phosphate stone, we will try to decrease pH, so we will use these drugs. We must recommend to patients with uric acid stones for diet without purine, such as coffee, chocolate, beans, etc. Sanatorium therapy, it includes different mineral water, which also depends on chemical structure. In acidic urine, in acidic stones, we will use mineral water which leads to alkalization of urine. And opposite, in cases of phosphate stone, we will use mineral waters which leads to acidification of urine. Next, promotion of stone expulsion, hydration and terpene drugs. What does it mean? No, we try to recommend to increase diuresis. If usual diuresis is about 1.5 liter, in these cases we recommend to patient to intake more than 2 liters of water, because increased diuresis leads to migration of small stone, which we, in cases when we hope that may be independent passing of stone, in cases when sizes of stone not more than 6 to 7 mm. Well, terpene drugs. What means terpene drugs? It is plant drugs, which have combined action. They have diuretics action, spasmolytics action, sedative action, and small anti-inflammatory action. Next, normalization of metabolic process. Now, in this picture, you can see allopurinol. What means that? This drug decreased production of uric acid. We said that uric acid is an end product of purine metabolism. If production of uric acid decreased, so decreased building material in urine, and possibility of stone formation decreased. Dissolution of stones. No, only urate stones, or uric acid stones may be dissolved. Only these stones. We already said that may result of chemical composition, the chemical analysis. Next, they are non-opaque. In urine we can find urea and other indirect symptoms allows us to think that stone is uric acid. And one of the most important also, I didn't tell you, pH 4.5 till 5.5, acidic urine. In these cases, we can use such drugs as Urolith-U, Blemarem. They lead to alkalization, but not only alkalization cause dissolution of stone. This mechanism is very complex, but you must remember that only urate stone we can dissolve. And anti-inflammatory therapy leads to decreasing of pyelonephritis, which complicates urolithiasis very often. Next, arresting of renal colic. No, it is one of the actions in treatment of the urolithiasis. We said that we already discussed in detail what mechanism of renal colic. It is acute obstruction of urinary paths, acute obstruction. And all our action might be directed on restoring of urine flow. And I didn't tell you also in diagnostic also for renal colic, we must estimate urine flow. No, we discussed, as you remember, differential diagnostics. If urine flow is disturbed, so we think about renal colic. If it is normal, in these cases, we can exclude renal colic, and so we must use any investigation which allows us estimate urine flow. So if the main problem which caused renal colic is acute disturbances of urine flow, we must restore it by any ways. Hot water bottle, hot bath leads to decreasing of spasm of smooth muscles of ureter or smooth muscles of the pelvis, and by this way maybe restoring of urine flow. Spasmolytics and sedative analgesics. Spasmolytics and sedative analgesics. Also, they removed spasm, and analgesic effect also. Sometimes, if it is not enough, maybe use narcotic analgesics. But narcotic analgesics we can use only in inpatient departments. Next, Novocaine blockade, Lorin-Epstein's blockade. That calls Lorin-Epstein blockades. It is a blockade of a spermatic cord in males and round ligament in female. This type of blockade may be effective in cases of distal localization of the distal localization of stone, in the lower third of the ureter, for example, when it localizes near urinary bladder. Now, how can we perform this blockade? We must palpate in the spermatic cord in the area of root of scrotum. We palpate it, perform punction of spermatic cord. First, Novocaine behind it, needle in direction of external rim of the inguinal canal, and we introduce about 40 ml of Novocaine. Next, catheterization of the ureter. If conservative measures are non-effective, when we cannot arrest renal colic, we perform catheterization of the ureter. How does it perform? We perform cystoscopy, a special cystoscope with the canal and special guide which directs catheter in the orifice of the ureter. We perform inserting this ureteral catheter into the ureter, and gradually we insert it upward, and when we meet obstruction, if small stone, we try insert this instrument upper than stone. If we insert it catheter upper than stone, this catheter will function as drainage, and urine which was accumulated upper than stone and distended ureter and the bilocalycial system, this urine will be drainage, it will excreted, discharged through catheter, and renal colic disappears immediately. Catheterization of the ureter. Sometimes, very rare, we cannot insert catheter upper than this obstruction. Maybe such cases. But in these cases, we will perform percutaneous nephrostomia. Next, indications for surgical intervention. Так. No uncontrollable marked pain which doesn't allow the patient normally live and work. 1. Next, large sizes of the stone, more than 8 millimeters. Also its indication for operative treatment. Next, non-effective conservative treatment. For example, you hope that small stone can pass through urinary paths independently, but long-term treatment is not effective. Or, for example, you decided to perform litholysis, dissolution of stone, but 2-3 months as you perform this treatment without effect. Understandable. Next, marked obstruction by the stone of the urinary paths with development of hydronephrosis. I demonstrated you macro preparates, I demonstrated you X-ray films with the marked dilation of the urinary paths. In these cases, to prevent progressive development of hydronephrosis and atrophy of parenchyma and loss of function of the kidney with the development of renal insufficiency, we must perform operative treatment. Next, organic encumbrances for outflow of urine, strictures, anomalies of development, etc. Now, if stricture present, it is narrowing of the ureter, for example, which was developed during long-term inflammation, or maybe congenital, sometimes strictures, and predisposing factor for stone formation remains in this case, and only operative treatment and operative correction of urinary paths can help to prevent next time formation of the stone. Or different operation in cases of anomalies of development, when constant chronic obstruction of urinary paths present. Next, gross hematuria, long-term gross hematuria also is one of the indications for operative treatment. Acute pyelonephritis caused by the stone, especially in cases when acute pyelonephritis which leads to purulent forms such as apostomatous pyelonephritis, carbuncle of the kidney, abscess of the kidney, etc. And such complication as calculous post-renal anuria also required urgent actions we must perform immediately, restoring of outflow by any way. First of all, if it is possible, by catheterization of urinary paths. If it is not effective, we must perform percutaneous nephrostomy, drainage of pyelocalycial system by tube which was inserted through punction, percutaneous punction. And if these actions are non-effective also, sometimes we must perform open operative treatment or instrumental. or endoscopical treatment, sorry. Well, this picture demonstrates you Dormia basket. On the left picture you can see stone which fixated by this basket and picture of the basket. When this basket is in the catheter, when we insert catheter upper than stone, we this basket and it opens upper than stone, and traction downward leads to fixation of the stone and evacuation. You can see also forceps, special forceps, which we can insert by visual control. For example, we use ureteroscope, and by this control we can fixate small fragments of stone, of small stones, by these forceps and evacuate outside. You can see X-ray picture. This, you can see stone which fixated by this Dormia basket in distal part of the ureter. And next, gradual traction downward leads to evacuation of this stone. In this picture you can see stone of the ureter. This picture we can see through ureteroscope, and in this case you can see fixation of the stone of the ureter by special forceps. This picture demonstrates insertion of nephrostoma, punctual nephrostomia. Under ultrasonic control, most often performs puncture of the pelvis, and then through special equipment insert tube, which right picture you can see this tube localized in the pelvis, and special loop material with the memory of this nephrostoma fixates nephrostoma in pelvis. Open stone surgery. Different operations may be performed depending on localization of stone. First, pyelolithotomia. What means pyelolithotomia? It is name. What means pylotomia? Pylotomia is incision of pelvis. Pylos, Greek term of pelvis. Pyelolithotomia means that stone removes through incision of the pelvis. What means nephrolithotomia? When incision performs through parenchyma of the kidney. I demonstrated you Stockholm stone. When one part was removed through pelvis, other part was removed through incision of parenchyma. Nephrolithotomia. Nephrectomia, partial or total. No, if atrophy of parenchyma already present, especially in purulent inflammation, sometimes perform partial or total nephrectomia. Total nephrectomia, you understand, might be performed only at the last resort. Ureterolithotomia, when stone localized in ureter, and cystolithotomia, removing of stone from the urinary bladder. In this picture you can see incision of pelvis and gradual removing of stone. Also variants removing nephrotomia, incision of the not only pelvis but also parenchyma. You can see this picture there. Removing of stone from the pelvis, pyelithotomy. In this case, nephrolithotomy, when stone removed through incision of parenchyma from the upper calyx. You can see kidney which was removed. You can see it. Long-term process leads to atrophy of parenchyma and loss of function of the kidney. You can see this stone, pelvis and stone, and in this case, pelvis without stone already. Last 40 years, new methods was development of new methods of lithotripsy. What means lithotripsy? It is crushing of stone. Maybe two types of lithotripsy. Maybe contact lithotripsy or distant lithotripsy or extracorporeal shockwave lithotripsy. What means contact lithotripsy? When contact presence between stone and special probe, special contact presence. Special contact between source of shock waves and stone. We insert this probe till stone by visual control, for example, cystoscope, ureteroscope, nephroscope. We apply it and perform action on this stone. We can use electrohydraulic effect, laser effect, Holmium-Yak laser, pneumatic, jackhammer effect, drilled, ultrasonic and mechanical. So in these cases, we apply this source to stone. Well, the most effective laser, last time, most effective laser, lithotripsy. What means extracorporeal shockwave lithotripsy? First of all, this source of shock waves localized outside of the body. It may be next physical effects, electrohydraulic also, electromagnetic and piezoelectric. In our lessons we will discuss in detail, but the main principle of this method is focus of these waves on the stone. Focus. Because what problem? Waves might be, forces of these waves might be enough for crushing of stone. But when they go through tissues, they must not damage it. The problem. How did this problem was decided? Focus. When I'll show just one picture moment. Look, please. Source of these waves localized here. A special spheric S-mirror, the reflector, special reflector. And when we switch on this source, waves which goes on the surface of this mirror, they will be reflected and they will go in one point. Every way when it goes through tissues, they don't damage it as well as it cannot destroy stone. But when they goes to this focus, their forces summarized and occurs enough for crushing of stone. It is principle of this method. The moment I go back. No, variant. contact lithotripsy, for example, ureteroscope inserts into the ureter till stone, and then we apply it to stone and perform crushing. Percutaneous nephrolithotomy. What means percutaneous nephrolithotomy? When we perform, we insert needle, then puncture by needle bilocation system, special technology present to dilate this canal, and then we introduce nephroscope, and through this nephroscope we insert probe, special probe, and we can use any variant of contact lithotripsy. Calycial access, dilation, nephroscopy, lithotripsy, removal of stone fragments from the kidney, forceps, and nephrostomy. And now I will demonstrate you. Look, please. Before this picture of nephroscope, which applies to the stone and by special probe performs crushing. Other variants, ultrasonic generation, and applies this probe to stone and performs crushing. And gradual picture, look this. Second stone, for example, or multiple stone. We perform puncture by needle. Then we introduce through needle special guide. Pay attention. Ureter is operated by a special catheter with the balloon, which doesn't allow for fragments pass through the ureter. Next picture, you can see performs dilation of this canal, gradual dilation of canal, and introduction of nephroscope. You can see nephroscope is inserted the pelvis, and then we use any variants of generation of waves for contact lithotripsy. After that, we perform, you can say, small fragment. They are removed by special forceps outside, and then nephrostomia remains in the pelvis, for drainage a few days. In this case, by flexible system, ureteroscope inserts special equipment till stone and performs crushing. Well, no, you can see this variant of extracorporal, the scheme of extracorporal lithotripsy. Well, and now I wanted to tell you that in cases of extracorporal lithotripsy, stone doesn't vaporize, stone doesn't dissolves, it crashes into the small fragments. And if these fragments are enough small, they can pass through independently along the ureter by normal urinary paths outside. But if sizes of these fragments are large, maybe obstruction of this ureter, for example, and may be complicated by renal colic, acute pyelonephritis, and etc. And this situation required instrumental removal of these fragments by inserting special instrument through urinary bladder, through ureter, fixation by forceps, and evacuation these fragments outside. And so, in all these cases, might be necessary equipment if such complication appeared to perform this action. And sometimes may be started from distant lithotripsy, but if large fragments obturate stone, it may be transformed into the contact lithotripsy in these cases. Well, and now more than 85% of the patients which required operative treatment may be operated by these type of treatment, lithotripsy, only in cases if organic strictures present or other organic disturbances of urine flow. In these cases, lithotripsy is contraindicated. Also, in pregnant women, we cannot perform lithotripsy, also contraindicated. This picture demonstrated crushing of stone. So, also you can see crushing of stones, and next migration through ureter. Ultrasound shock waves, crush stones. No, but ultrasound may be used only in case of contact lithotripsy. In this picture, you can see equipment for distant lithotripsy. More detail, we will discuss it in our lessons. Our lecture is over. See you in our lessons. Goodbye.